I'm Ian Calder, and I'm a consultant anaesthetist at the National Hospital for Neurology and Neurosurgery and the Royal Free Hospital. The concept of not giving a muscle relaxant before you ventilate is not evidence-based. It is an armchair idea that somebody thought of, and it sounded like a good idea, and it somehow entered the textbooks. I think people now feel this sort of worry that they're going to be criticised if they give a muscle relaxant. And one of the sort of offshoots of that has been this idea that if you induce somebody, you shouldn't then give them muscle relaxant until you've proved that you can ventilate them with a face mask. Well, that's absolutely fine, provided you know what you're going to do when you find that you can't ventilate with a face mask. So what I do is give the induction agent and give the relaxant straight away. If I've given full doses of induction agents, which I hope I have, guaranteed the patient is properly anaesthetised, they're not going to wake up before they become hypoxic, or at least I would certainly not like to rely on that. And I know that my chances of being able to handle the airway, either by ventilation of the mask or a laryngeal mask or to intubate them, are much higher if I've given a muscle relaxant. We're very fortunate now because of excellent work that's been done in Michigan by Sachin Ketapal and Kevin Tremper. They've got 53,000 people that the anaesthetists felt were suitable for general anaesthesia, and they were induced, and face mask ventilation was attempted. And we now have their data, which is that out of that 53,000, 0.15%, which was 77 patients, proved impossible to ventilate with a face mask. The really encouraging thing that's come out of that is that although these patients were impossible to ventilate with a face mask, all but one was possible to intubate. I mean, some with difficulty, but they managed to intubate, in fact, 73 out of the 77. One had a cricothyrotomy, and 3 patients were awoken. Now, in order to facilitate the intubation in the patients that they found that were impossible to ventilate with a face mask, what happened was they were given a muscle relaxant. So, when in practice the anaesthetists in Michigan found that they couldn't ventilate with a face mask, what they did was what I would have done, is they gave a muscle relaxant and they sorted the situation out. They intubated the patient. And I'm very grateful to them because that now gives us some evidence to back up the attitude that was prevalent when I was an SHO, when I was training, which was that muscle relaxants are very, very much more often the answer to our airway problems than causing a problem themselves. The other paper that's been, I think, very, very important publication was in October at the BJA last year, and this is from the Royal National Throat, Nose and Ear Hospital. They've been looking at people with stridor. They've shown very elegantly that if you try and measure the gas flows that these people can achieve when they're awake, if you try and breathe them down with sevoflurane, which has become a sort of dogma, their gas flows get much worse. Whereas if you give them propofol and atracurium, paralyze them, and give them positive pressure with a laryngeal mask, their gas flows improve enormously. The concept of paralysing somebody who has stridor, something that I think has worried a lot of people. They felt that's inherently an unsafe thing to do because you might not be able to positive pressure ventilate. But Anil's work seems to show that actually it's the other way around. So I'm very grateful to them because now if you've got somebody there with a stridor and you feel that a muscle relaxant might help, you've got the evidence to back you up.